Maybe over 20 years I read in some, I don't know, really I don't know where I read that. I read about the superior cell infiltration. So which literature?
See, every literature talks about it, sir. LA infiltration is divided into supraperiosteal, subperiosteal,
I never
interosseous.
seen this in Malabar. I never seen
No,
that.
it doesn't say that you do it for a failure. It never says you do it for a failure. The classification starts infiltrating, depositing LA in the periapical region. Okay, after doing this, there are different techniques. One is mucobuccal, one is supraperiosteal, one is supraperiosteal, then comes the intraosseous, then comes the intraligamental, intrapulpal. It comes under the classification.
Okay.
Only
really it's working a lot.
And the only problem is the prick you give, they have severe pain.
Stretching of
Sometimes even 2 to 3 days, that particular area they have periosteitis. Otherwise, the LA will work very nicely.
Especially in acute pulpitis cases, when we open for endodontic cavity, we used to be very scared to open it. So when I went with the superior cell infiltration, it was working.
It will work nicely.
My second thing is, when I did my undergraduation, we've been taught this with Fisher 1-2-3 technique. But nowadays, the newcomers, I haven't seen them, they're using that techniques. Is it really Fisher 1-2-3?
Sir, actually, as I explained to you, you are giving the LA into the pterygomandibular space, medial aspect of the ramus, which I showed. Fisher's 1-2-3 technique is almost like a direct block. Only thing, it explains our position. 1, 2, 3. Otherwise, only the name changes, sir. But the technique is same. Fisher's 1-3 and is same thing. See, the first is for the painless, then second only the position they go to the. It's given in morning, sir.
Okay.
Fisher's 1-2 technique is given in morning.
But not taught in.
No. Name changes. The name changes. That's what see. Today's is only basics. Direct blocks, that's the same. Direct block, nobody directly pokes and goes away. They also 1, 2, 3 for the long buckle. Okay. They have named it. Fisher has named it, but nobody is following. According to me, Fisher's and direct is same.
Can I add something?
Sir, direct long buckle.
No. You have to take it out and give it in the buckle.
So before that, I will call upon our moderator on the dais to join us on the discussion.
Between the Fisher's 1-2-3 and direct technique, the main thing is depth of penetration of the needle. If more than half of the needle is gone in, then you are in the direct technique thing and you are in the right place. If you are not hitting, then you are anterior. So you take it as Fisher's 1-2-3. You give surface anesthesia, come to the same side and go in a little bit deeper. Opposite side, and it will go more than halfway. So this is how you need to take it. So more than 50% in, you can directly give. Illana, you use this Fisher 1-2-3 manual.
That is more than direct rather than Fisher 1-2-3. You should be more experienced if you go for that.
In the sense, it is not experience. Even now, you definitely can't. It's depending on the anatomy of the ramus actually. So, anti-right, the thing for successful anesthesia is 50% of the needle should have gone in. And in both the things, you need to give long buccal separately. Except for higher Gaugates and things like that, everything you need to give long buccal separately.
Correct. And one more thing, I actually don't want to go in deep about this. Actually, Fisher's also you have to feel the bone. The height is different in Fisher's. Direct, I told you corona and notch. A simple thing is from the last molar, 1 centimeter. Fisher's will be slightly, and second thing, as he told, it is deposited in the pterygomandibular space without any landmarks, so material will diffuse.
That is a fantastic presentation, very enlightening. To add a couple of points to what Dr. Murugesan has spoken about the use of cartridge syringe. So that really wonders because the needle is very, very thin and it will be very atraumatic. And for, I know that it looks little intimidating in front of the patient, but then the pain for the psychological aspect that he was talking about, whether it is Kamalasan or Nayanthara, sometimes those patients, even if it is Nayanthara, the pain is pain. So they won't sometimes accept, they'll call Kamalasan to give the LA, not Nayanthara's. And that is one. Next thing is, yes, he was spot on, Dow gates. See, when we assess the patient in our private practice, that the patient is little apprehensive, go straight, give a Dow gates. You can be comfortable doing any procedure for the next 2.5 hours. And it works. The success rate is more than a direct block or Fisher 1 to 3 or whatever it is.